You break your arm, right? The x-ray shows a jagged white line. And, well, the orthopedic surgeon just points and says, there it is, it's broken.
Yeah, it's right there in black and white.
Exactly. We love that binary. It's comforting, But you step into the world of everyday primary care, into the standard 15-minute consultation. And that binary illusion just shatters.
It really does.
The clinical reality is murky, and frankly, the x-ray machine is often just a distraction from the real treatment. Welcome to the debate.
Glad to be here.
Today, we are looking at a fundamental tension in modern healthcare practice, and we're analyzing it through the lens of a standardized clinical consultation. The scenario is a 45-year-old patient. Let's call him David.
Okay, David.
Yeah, and David presents to a family medicine clinic with a persistent cough and some chest discomfort that has lasted for almost 2 weeks.
And honestly, it is a textbook presentation. It's the kind of case a primary care physician sees, a dozen times a week easily.
Exactly. But it raises a really profound core question about the very nature of medicine.
Right.
When evaluating a standard medical encounter like this one, is the primary value of the consultation found in its rigorous diagnostic investigation, or does its true efficacy lie in its function as a behavioral intervention?
A classic science versus art debate.
Exactly. And I will be arguing that the consultation is fundamentally a diagnostic exercise. The value rests entirely in prioritizing symptom timelines, physical examinations, and, structured clinical pathways to rule out severe pathology.
Well, and I will be arguing that the visit is primarily a vehicle for behavioral intervention.
Oh, really?
Yeah. The true clinical mastery here isn't diagnosing a cough. It's using the patient's acute symptoms as leverage to address a long-term, life-threatening lifestyle habit. The diagnostic work is simply the scaffolding for the psychological intervention.
Okay, well, let's lay out our positions clearly. When you look at the structural integrity of this consultation, it is entirely driven by the diagnostic process.
I don't know about entirely.
It is. Every single question the doctor asks serves to methodically eliminate variables in a differential diagnosis algorithm. She establishes the timeline, which is almost 2 weeks.
Right, she does do that.
She checks the nature of the symptom. It's mostly dry, but with a little mucus. She explicitly rules out current fever, and she clarifies the trigger for the shortness of breath, noting it only happens when climbing stairs.
Sure.
These aren't conversational pleasantries, right? They are vital data points that dictate the entire trajectory of care.
They are data points, yes, but look at the context in which they are gathered.
But she goes further than just the acute symptoms. She checks for comorbidities, asking specifically about asthma, diabetes, high blood pressure.
Right, standard intake.
And she verifies there are no known allergies. All of this happens before she even takes out her stethoscope to listen for a slight wheeze. I think this proves that the ultimate goal is purely clinical.
Well, let me jump in here.
It culminates in an actionable chest x-ray and a prescription. The communication frameworks utilized in these standardized encounters, like the polite introductions, the open questions, they exist merely to facilitate accurate data collection. The doctor is basically a biological detective, and the protocol is designed to solve a biological mystery.
I've actually viewed the exact same sequence of events through a completely different lens.
Color me shocked.
If we look closely at the objective diagnostic findings in this scenario, they're incredibly mild. The patient's fever is already gone.
True.
The lungs are, in the doctor's own words, mostly clear, save for a slight wheeze. And she explicitly states that at this stage, it doesn't appear serious. Therefore, the true clinical triumph of the encounter isn't the discovery of a disease, it is the pivot to behavioral modification.
You're referring to the smoking cessation.
Precisely. The doctor leverages the patient's acute chest discomfort and pressure to address a 20-year 10-cigarette-a-day smoking habit.
Right.
The framework of polite introductions and empathetic responses isn't just for data collection. It is a highly sophisticated psychological tool.
A tool, sure, but not the main event.
But it is. If this visit was just about fixing a 2-week viral cough, it would be completely trivial. By addressing a 20-year addiction, the visit becomes life-altering. The communication skills are the actual intervention.
Wait, but to claim the communication is the intervention fundamentally misinterprets how a doctor extracts unbiased data. Let's look at the mechanics of the communication for a second.
The mechanics are entirely based on rapport. The standardized skills demonstrated here include polite introductions, showing empathy, and checking patient understanding.
But those are just pleasantries.
No, they aren't. When David says the cough isn't getting better, the doctor immediately responds, "I'm sorry to hear that." That is not a diagnostic probe. Empathy serves a profound behavioral function here.
Okay, but empathy is entirely subjective. Are you seriously suggesting a clinical pathway relies on the patient feeling warm and fuzzy?
I'm suggesting it relies on neurology. Empathy lowers cortisol.
Cortisol. Okay.
Let's talk about the physiological stress response, right? When a 45-year-old smoker walks into a clinic with chest pressure, his sympathetic nervous system is highly activated.
Well, obviously, he thinks he might be dying.
Exactly. He's been smoking since he was 25. He knows it's bad for him. He's anticipating a lecture, which means he's in a state of defensive psychological posturing.
Okay, I follow that.
And that stress response literally blocks new information uptake in the brain. If the doctor approaches him purely as a biological mechanic, he will put his guard up instantly.
Right.
By establishing empathetic rapport, she lowers his cortisol levels and creates the psychological safety required for behavioral change. If he feels judged about smoking, he will never accept the cessation support at the end of the visit.
Wait, I see why you think that, but let me give you a different perspective.
I have to stop you there.
Go ahead.
I understand the cortisol argument, I do, but leaning on empathy as a primary goal risks contaminating the actual clinical data. I would argue that the communication skills, specifically the use of open questions, are strictly empirical tools designed to prevent diagnostic bias.
Bias?
How does an open question prevent bias? It just lets the patient talk.
It prevents the doctor from accidentally programming the patient's memory.
Oh, come on. Programming?
Yes, programming. When the doctor asks, "Could you describe your cough?" she is employing a precise scientific technique. In medical diagnostics, an open question prevents the confirmation bias of the physician from altering the patient's narrative.
Okay. Explain what you mean.
Think about the mechanism. If the doctor asks a closed question first, like, "Are you coughing up green mucus?" the patient's brain immediately searches for any memory that matches.
Right.
They remember they cleared their throat forcefully this morning, and suddenly they say yes. You've just created a false clinical pathway. You've contaminated the evidence.
I mean, I guess, but she does pivot to closed questions almost immediately after that initial open query. She asks, "Have you noticed any fever? Any shortness of breath? Do you smoke?"
Because the open question casts the wide net to capture the untainted chief complaint. You know, David says, "It's mostly dry, but sometimes I cough up a little mucus."
Right. She gets the baseline.
Exactly. Once that evidence is collected without memory programming bias, the doctor must immediately shift into the rapid-fire binary diagnostic algorithm to rule out red flags.
Binary. Again.
Yes, she isn't asking about diabetes to make him feel heard. She's asking because diabetes is a mechanism for systemic failure. High blood sugar impairs peripheral blood flow and macrophage function, turning a minor chest infection into a full-blown crisis.
Sure, the biological factors matter.
The communication strategy is entirely subservient to the data collection required to keep the patient physically safe.
The data collection is necessary, of course. But you're treating the patient like a biological hard drive that just needs the right query to output the correct file.
Well, in a diagnostic sense, they kind of are.
No, they aren't. The reality is that the healthcare system is a massive conveyor belt that processes human beings as data points. The empathy, the rapport, the behavioral pivot, these are profound acts of rebellion against a hyperclinical system.
Acts of rebellion? That's a bit dramatic.
It's true. But even gathering that unbiased data creates a new problem. When David openly admits to chest pressure and shortness of breath, his anxiety spikes.
Naturally.
The doctor now has to manage that fear before she can do anything else.
And I'd argue that fear is exactly why the diagnostic imperative is paramount. Following that history-taking, she immediately pivots to a physical examination.
Yes, she does.
She listens to his breathing, detects a slight wheeze, and what is her immediate response to that objective clinical finding? She orders a chest X-ray.
But wait, you're completely glossing over the sequence of how she delivers that information.
Am I?
I'm sorry, but I just don't buy that the X-ray is the most important part of that moment. Let me tell you why. When the patient explicitly asks, "Is it serious?" what are the very next words out of the doctor's mouth?
She says it doesn't appear serious.
Exactly. She says at this stage it doesn't appear serious. She provides explicit reassurance before the x-ray is even taken.
But tell me this, if the x-ray comes back entirely clear, doesn't that actually backfire?
How would it backfire?
Doesn't the patient just think, great, my lungs are perfectly fine, I can just keep smoking 10 cigarettes a day? The reassurance seems incredibly risky without the imaging to back it up.
That is exactly where the concept of the teachable moment in behavioral psychology comes into play.
Okay, explain that.
The reassurance doesn't backfire. It's the catalyst. David is experiencing physical vulnerability. He has a 2-week cough and chest pressure. His decades of cognitive dissonance about smoking are momentarily broken by the reality of his own mortality.
Right, he's scared.
But his cognitive load is maxed out by acute panic. Imagine if she had said, I hear a wheeze, it could be cancer, let's get an x-ray.
He'd be terrified.
He would be completely terrified. He wouldn't hear another word she said about quitting smoking.
So you're saying the reassurance is tactical?
It is highly tactical. By reassuring him that the acute situation isn't catastrophic, she lowers his immediate anxiety just enough to make him receptive to the subsequent, much more important warning.
The smoking warning.
Right? She says, I'd also strongly recommend reducing or quitting smoking because it can delay your recovery and increase the risk of lung disease. She ties his acute, mild discomfort directly to his chronic habit. The current illness becomes a tangible manifestation of the lung disease she is warning him about. That is brilliant behavioral psychology, and it directly prompts his admission, when he says, I've been thinking about quitting.
I mean, that is a fascinating way to frame the teachable moment. But I still see the x-ray as the non-negotiable core of the visit. Not just a psychological prop.
It's not a prop, it's just secondary.
A slight wheeze in a 20-year smoker is a massive clinical red flag. It could be early-stage COPD, bronchial carcinoma, or acute bronchitis.
Sure, which is why she checks.
The doctor relies on objective imaging because the stethoscope just isn't enough. She needs a radiograph to definitively look at the lungs and heart. If the x-ray comes back showing a mass, the entire behavioral intervention regarding smoking cessation becomes completely secondary to immediate oncological triage.
Well, obviously.
You can't counsel a patient on lifestyle choices if they have undiagnosed active pneumonia or malignancy. The diagnostic investigation is the foundation, or the entire house collapses.
But the x-ray is just confirming what her clinical intuition already suggests, which is that the lungs are mostly clear. Yes, ruling out malignancy is standard protocol, but the true danger to David's life isn't this specific 2-week cough.
No?
No, it is the 2 decades of smoking. Which brings us to the exit strategy of the consultation. We really need to examine the final instructions given to the patient to see which philosophy dominates the ultimate outcome.
And if we look at that exit strategy, the clinical diagnostic focus is undeniable. I want to draw your attention to the safety netting.
The escalation parameters.
Exactly. The doctor gives highly specific, acute clinical parameters for when the patient needs to escalate care.
Right.
She says to drink fluids and get rest, sure, but the crucial instruction is return immediately if you develop a high fever, difficulty breathing, or severe chest pain.
Standard advice.
Think about the precision of those 3 indicators. High fever indicates a systemic infection taking over. Difficulty breathing indicates respiratory failure. Severe chest pain indicates a potential myocardial infarction. This proves the consultation's ultimate priority is mitigating acute physical danger and completing the diagnostic safety loop.
But doesn't every doctor have to do that? That's purely defensive medicine.
It is clinical risk management. The doctor is explicitly acknowledging the limits of her current diagnostic snapshot. She is essentially saying, based on the biological data I have right now, you are safe, but if X, Y, or Z variables appear, my diagnosis changes and you are in immediate danger.
Right.
That safety netting is the most critical intervention of the entire 15 minutes.
I mean, I understand the necessity of the safety net, but let's look at the actual statistical reality of the patient's future. Okay, let's...
The unique transformative value of this specific consultation isn't telling a middle-aged man to go to the hospital if he has a heart attack. It is the offer of ongoing systemic support. She tells him, we can provide support to help you stop smoking.
She also writes him a prescription to manage the acute cough.
A prescription that is essentially a Band-Aid. The cough syrup masks a symptom. The true treatment, the intervention that will actually alter this man's long-term morbidity and mortality, is the behavioral support system she introduces.
I think that's a bit dismissive of the cough syrup, but go on.
If David goes home, takes his cough syrup, gets better in 3 days, and continues to smoke 10 cigarettes a day for another 20 years, the medical system has fundamentally failed him.
Has it? Yes, and it has failed him regardless of how perfectly the diagnostic algorithms or safety netting parameters were phrased.
I don't think you can call it a failure of the medical system if a patient exercises their autonomy to continue a destructive habit.
But the doctor has a role in changing that habit.
The doctor's duty is to diagnose, inform, and offer treatment. The doctor correctly diagnosed the acute issue, informed him of the risks of his habit, and offered support. The burden of action ultimately lies with David.
But notice the phrasing she uses. We can provide support.
Right.
That specific language shifts the burden of quitting from a solitary, willpower-based struggle to a collaborative medical process. It signals that the clinic can offer nicotine replacement therapy, cognitive behavioral therapy, or support groups.
Okay, that's fair.
By making the clinic a partner in his behavioral change, she extends the value of the consultation far beyond the 15 minutes they spend in the room together. The behavioral intervention doesn't end when he walks out the door. It actually begins there.
That's an interesting point. Well, we are nearing the end of our time, so let's summarize where we stand on the nature of this consultation.
Sounds good.
From my perspective, if you strip away the rigorous diagnostic framework, if the doctor doesn't methodically establish the timeline, check for comorbidities that alter macrophage function, listen carefully to the lungs, and order the objective validation of a chest X-ray.
You're saying it's negligent.
Yes, the consultation would be medically negligent. A polite, empathetic conversation about quitting smoking is completely useless if the patient drops dead from an undiagnosed cardiac event or severe pulmonary infection a week later.
Fair enough.
The clinical investigation must be paramount, because physical survival is the prerequisite for behavioral change.
And my summary is that while the diagnostic checklist is undeniably necessary, it is merely the baseline expectation of the profession.
Just the baseline?
It is the absolute minimum requirement. The consultation's greatest achievement, its true clinical artistry, is utilizing empathetic communication to successfully navigate a defensive 20-year smoker toward a teachable moment of vulnerability where he actually admits he wants to quit.
Right.
Without the psychological tools, the open questions to prevent bias, the empathy to lower cortisol, the strategic reassurance to reduce cognitive load, the doctor is just a data processor on a conveyor belt. It is the behavioral intervention that actually has the power to add decades to this patient's life.
It seems we are looking at two sides of the same coin here. I think we can both acknowledge that the highest level of clinical practice requires a seamless integration of both perspectives.
Absolutely.
A physician must be a master of evidence-based diagnostic pathways, utilizing algorithms and objective testing to keep the patient safe from immediate harm.
Exactly.
And simultaneously, that same physician must apply the nuanced, empathetic communication skills necessary to inspire patient compliance and facilitate long-term lifestyle changes.
Right.
You cannot have the science without the art, and you really cannot have the art without the science.
Well said.
As always, we will leave it up to you, our listeners, to draw your own conclusions. We encourage you to reflect on the dual nature of medical consultations next time you find yourself sitting on that exam table.
Definitely.
There is always more to explore in the material, especially when observing how effectively medical professionals balance clinical investigation with behavioral psychology.
It really is a fascinating tightrope walk between processing data and connecting with a human being.
It is. Which brings us back to where we started. We so often want medicine to be that perfectly clear X-ray,
Yeah.
A jagged white line that tells us exactly what is wrong and exactly how to fix it.
But a human being isn't a simple machine. You can't just wrench a habit out of a person the way you set a bone.
No, you really can't. And as long as we are dealing with human biology intertwined with human behavior, we will always be navigating those diagnostic muddy waters.
Beautifully said.
Thank you for joining us. We will see you next time on The Debate.